Good afternoon, everyone. John Snyder here from Newton-Wellesley Medical Group Lunch and Learn, another Thursday afternoon. We are so happy to invite Dr. Megan Mystery to come talk to us about opioid prescribing in the primary care and potential pitfalls. And we wanted to tease upcoming Lunch and Learns. Next week, we have talking about to biopsy or not to biopsy, or the new thyroid biopsy clinic, and how to handle those thyroid nodules. Following week, we're excited to have Dr. Kosha Thakor here talking about microaggressions, and then following Dr. Jason Simon, leg pain. And of course, on the 11th is a hospital holiday, so we will not be in session then. That's Veterans Day. Wanted to make our folks aware, given the high volume in the emergency department, this our orthopedic walk-in is open 7 days a week, 8 to 8, Monday through Friday. So injuries on the soccer field after school or things like that, please take advantage of being able to see a staff by orthopedic physician assistants and board certified orthopedic surgeons. We are there 7 days a week, x-ray and casting and bracing, all on site. Wanted to make folks aware of another learning opportunity from the Division of Palliative Care. They have a bi-monthly conference. This one is Hospice in Practice, given by Dr. Seaver, and she is our palliative care medical director at Good Shepherd, and that is going to be Tuesday, October 19th. So please be on the lookout for that link. That does look to be an interesting conference for us. Next slide. Oops. Okay, let's see. Having trouble advancing because every time I click on that, it was going to, okay, can you see this? Can you see the show now? Yep. Okay, I'm going to turn it over to Megan. Thanks, Megan.
Sure. Thank you, John Snyder, for inviting me to speak today. Today, I'll be talking to you about opioid prescribing in primary care, potential pitfalls with that, how to avoid this, and prescribe these medications safely. Next slide. You can advance now, John. Thanks. So, as John said, I'm Dr. Megan Mystery. I've been working for Newton-Wellesley Hospital since 2011. I work for Newton-Wellesley Hospital Primary Care in Needham. I completed my residency at Bay State Medical Center in Springfield, Massachusetts. After that, I worked for the Holyoke Health Center to fulfill my National Health Corps scholarship obligations. Part of my responsibilities there was an opportunity to work at the Ludlow Correctional Facility, which is a medium security prison. And while I worked there, I was able to start a treatment plan to identify new HIV and hepatitis C diagnoses in inmates, and then transfer them back to the community to continue their care and recovery. So that was a really meaningful position for me. After that job, I was a hospitalist for a little while before moving east and then being hired by Newton-Wellesley Hospital. I work in Needham doing primary care with our fantastic office of practitioners, doctors, PAs, and administrative staff. Next slide. So to begin my talk today, I thought I would touch on the CDC guidelines regarding opioid prescriptions. Clinicians should consider opioid therapy only if expected benefit to both pain and function are expected to outweigh risk to the patient. Next slide. Also, 10 opioid guidelines are suggested, and most of these you'll be familiar with. They should not be used as first-line therapy, should only be continued when benefit exceeds risk, should occur only after a discussion of risks and benefits, started with an immediate release formulation at the lowest effective dose, given for a short duration for acute pain, evaluate frequently for benefit and harm, incorporate risk mitigation strategies, review the state prescription data, and employ some routine urine toxicology testing. So there are some circumstances when it is medically appropriate to prescribe opioid medications. In particular, when you inherit patients from other practitioners who are on long-term opioid medications, when you treat patients with chronic non-cancer pain when they do not respond to other modalities, and patients with cancer-related acute or chronic pain. Next slide. So how do we do this safely? Well, I'm going to be talking about appropriate documentation, the use of the opioid agreement, the frequency of follow-up, the use of urine toxicology, the morphine milligram equivalent, the opioid risk tool, the use of Narcan prescriptions, the PDMP, and then how to recognize potential red flags with these patients. Next slide. So when we talk about documentation, this is really important. When you see a patient and you document in your note about your visit, you really need to make sure that the primary diagnosis is as specific as possible, such as L4 disc herniation with chronic pain or chronic pancreatitis. Diagnoses such as low back pain or chronic abdominal pain are not specific enough. We need to be as specific as possible with our diagnoses. In the documentation, you should include past therapeutics and interventions with outcomes, consultations from rheumatology, orthopedics, or pain medicine, and then the plan in place for pain control, what scripts you give, and then the follow-up. This is sort of the basic outline of what should be in every note. The Opiate Agreement is a very useful tool. Ideally, it's signed yearly with your patient and scanned into Epic. You can get this form directly from your Epic home screen under Resources, then Handbook, and on the top left in your handbook, you'll see Forms and Documents, and then you can print it out. I keep a folder with these agreements in my room, and my medical assistant gives them to appropriate patients to look them over before I come into the room. These can be used for any medication, for benzodiazepines, for amphetamines. When I talk to providers about this, they're usually really surprised that you can do this, but it's a very helpful tool. So you can amend these agreements for individual preferences, such as when and how a patient should request refills. For instance, what days should they call or not call, depending on when you're in the office, what the protocol is for lost pills or early requests, and what pharmacy they will use. I always give the patient a copy of this agreement and then again scan it into Epic. Now, this is not a legally binding document. That's important to remember, but it is a really great tool for you and your patient to really discuss what the responsibilities are regarding these prescriptions. The frequency of follow-up, I recommend that our patients who are stable and on chronic opioid medication, that they should be followed every 3 months. Of course, if there's changes made, you'd follow them more frequently, but if they're stable, that's sufficient. These visits can be a combination of virtual or in-person visits. And you always want to ask, where are the medications kept at home? Where is the Narcan? Are the medicines locked in a container away from children? Talk about the use of alcohol or other substances, the presence of depression or suicidality, and then talk about what social support systems they have. Next slide. Urine toxicology. So patients on long-term opioid scripts should have a urine toxicology at least once yearly. You order this as a drug of abuse panel, and this is done in-house. It costs about $3.50 a test. It's a rapid immunoassay, and it checks for synthetic opioids such as oxycodone, morphine, heroin, codeine, fentanyl, and methadone. Now, if you get an unexpected result, some type of confirmation test should be ordered. This can be a confirmation lab for the individual agent that you're looking for, or a pain management profile. The confirmation lab can be as a lab add-on if it's done within 3 days, and you would order that as a lab add-on, urine for whatever substance you're looking for. That costs about $31. If you send out a pain management profile, that goes out to the Brigham. It's $71 a test, so it's significantly more expensive. Now, my favorite option for what to do when you get an unexpected urine tox result is to do an e-consult with our lab. This is a fantastic resource. It goes right to our pathology lab. They'll look over the results of your urine toxicology test, and they'll review your patient's chart, and then they'll get back to you with what they recommend you do next. There are false positives with urine toxicology, and some of the most common ones are trazodone causing a positivity for fentanyl, or sertraline or any SSRIs causing a false positive for benzodiazepines. So I recommend always doing some type of confirmation test or an e-consult with our lab prior to addressing any inconsistencies with the urine toxicology with the patients. Next slide. The next thing I'm going to talk about is morphine milligram equivalents, or MME. This is a value assigned to determine the potency of the opioids given. Guidelines recommend that between 12 and 50 MME a day is, quote, safe, but remember that over 50 doubles the risk of overdose and is not associated with an increase in pain control. So you obtain this MME value by taking the total daily dose and adding it to the dose times the conversion factor. For example, if someone's on oxycodone 5 milligrams QID, the dose would be 20 milligrams of oxycodone plus the conversion factor, in this case, 1.5 times 20. So here are some common conversion factors, and I will add a link to the other conversion factors. And what I do with this value is I always include it in my note, but if you were to inherit a patient from another provider who is on, say, 70 or 90 MMEs a day, it can be used as a data point for the conversations that you have with the patient when you talk about tapering them down to a safer dose. Next slide. The opioid risk tool I want to briefly touch on. It's valuable if you're considering giving a patient medicines for acute pain. This is a tool that assigns points for family and personal history of substance use disorder, age, gender, history of sexual abuse, or psychological disease. If a patient scores a 3 or lower, this is a helpful data point if you're deciding to prescribe this patient opioids for acute pain. If they score higher, you're really considering other modalities for pain control would be important. And again, if you put this on your note, it's very helpful in the documentation. Next slide. Narcan. Narcan's a nasal spray. It's given as a script to patients, and when they fill it, they would use 1 spray intranasally prior to seeking emergency assistance for an overdose situation. You should review the use with the patient and their support systems. And when you talk about this medicine, remind patients and support system that this medication can save lives. It's explained to patients why they have this in the home. This can be used to the patient who may accidentally overdose on their medication, or used for someone who comes into the home and takes the medication if they find it. Now, Narcan nasal spray can be purchased without a script. The cheapest I found was at CVS for $94.99, but it is covered by most insurances. Make sure you always ask where it's kept in the home and that everyone knows how to use it. Remind them that it's effective for 30 to 90 minutes and oftentimes need to be readministered a second time. So that's why it's really important that the patient goes and seeks emergency assistance after an overdose situation, even if Narcan has been used. Next slide. The PDMP, we all know about this. It's the Prescription Drug Monitoring Program. I mention this because this facilitates communication with the providers and patients. It's an online database that helps to identify possibly misuse or diversion, and it should be checked each time a narcotic or a benzodiazepine is prescribed and the first time an amphetamine is prescribed. It should be documented on the script. For example, the P&P checked on such and such date. You should work with your medical assistants on a workflow that makes sense for you. My medical assistant checks this for me and puts it on the script before I fill it. I always will talk to patients before I prescribe them these medications. I'll talk to them about the existence of the PDMP and about how this is a monitored program and that we will be checking it on an ongoing basis so that they're aware. Next slide. So recognizing potential red flags is a really important part of this talk. Certain things that can happen when patients are on these medications that might cause you alarm might be breaking agreement guidelines, such as early requests or lost pills, a PDMP alert. A patient might mention ingesting additional pills or other pills belonging to other patients, missed appointments, reluctance or refusal to complete a urine toxicology, positive or negative urine toxicology, frequent calls to your office, or you may get calls from family or support system that they are concerned about your patient and their behavior. Next slide. So what do you do if you recognize these potential red flags? I recommend that you schedule an appointment, and this really should be in person and not a virtual visit. It should be really stressed to the patient that this is an important visit, that they come. You might consider scheduling this around when their medication would be due for refill. Before you enter the room, just take a deep breath. make sure that you just remember that you're the trusted medical provider and that your ultimate goal is the health and safety of your patient. Try to take any judgment or preconceived notions about what may be going on. When you get into the room, talk to your patient about the reasons for their visit and listen to their concerns. If you can remember back to elementary school, if you ever called to the principal's office, then you know exactly how your patient feels before you come into the room. These are difficult conversations for everyone. So like I said, you want to listen to your patient and let them talk about what their concerns might be, what their point of view might be about this situation. Reflexively stopping medications is not always the next step. You may decide to taper them down. You may decide to see them more frequently. You may decide to rewrite their agreement that I discussed earlier. But in the end, you'll collectively decide on a plan to move forward. You'll discuss what happens if the event recurs or another red flag occurs. And you want to remember to remind the patient that you're their medical provider and that your ultimate goal is their health and safety. Next step. Recognizing that these are difficult conversations, remember that we have support. We have support with the SES clinic, the behavioral health team, and the recovery coaches, the pain clinic. And please don't forget about the Massachusetts Consultative Service for Treatment of Addiction and Pain. This is a great resource. You'll get a call back from someone who is a certified addiction and pain specialist within a half hour, and they can talk to you about your patient care situations. This is really helpful. I'm always available to provide education and support around these challenging issues. Send me your consults via clinical message or email. Next slide. I want to talk briefly about vocabulary. Words matter. Words can unintentionally perpetuate a negative stigma and shame surrounding substance use. Use of the correct terminology here shows more compassion and reduces harmful stigma that can discourage treatment. We're leaders in our community, and it's really up to us to educate other providers and patients and their families about the correct verbiage here. For instance, instead of using the term abuse, use the term using, harmful use, problem use, substance use disorder, or misuse. Instead of using the term addict or alcoholic, use the term person with substance use disorder, person receiving treatment services, or person with use disorder. Clean or sober should be replaced with in recovery or not currently using. And please, instead of using the term replacement therapy, use medication-assisted treatment. I want to end with a quote that was in the Boston Globe last Sunday in an article about Newton-Wellesley Hospital's purple flag display that commemorated Recovery Month. In it, our own Dr. Barveld talked about the importance of using the appropriate language when speaking to patients as well as other providers. She said, "Addiction is a disease. It is not that our patients have committed a moral failure or are not strong or have an underlying mental illness. It is a disease, and there is hope and there is treatment." That's all I have. Any questions? Thanks for having me today, John.
Thanks, Megan. That was really great. I don't see any questions in the chat. Feel free, we have a few minutes to put a case or to raise your hand or to speak up. Megan, one thing that I find while we're waiting for others, if they want to participate, is the patient who's on chronic pain medicine for a chronic problem gets an acute injury.
Right.
Yeah. So how would you advise us as PCPs to manage, the broken ankle on someone who has chronic low back pain?
It's a really great question. I think it's a good time to think about using some of the resources, such as a consult to the pain clinic or to myself. But generally, if a patient is on chronic opioid therapy, like if they're on, I don't know, OxyContin twice a day or something like that, you can give a short acting. First of all, you want to use non-opioid medications at first, if you can, like, non-steroidals or things like that. But you can give a short course of, say, oxycodone or an immediate acting medication just for a very short course. But I think education is just really important there.
And do you have any favorites, favorite medicines, and besides from the NSAIDs or other medicines that you use for chronic pain to lower the MME on your patients that you found useful?
You mean in terms of an acute on chronic situation?
Or just a chronic situation in general?
Yeah, it's really difficult, especially like I mentioned with patients that we inherit that might be on 70 or 90 a day. It's a really gradual thing. I tend to steer away from things like fentanyl, but I mean, I think what I do is utilize Dr. Baraveld and the pain center to give me recommendations. But in general, I'll slowly decrease the long acting using, immediate acting for breakthrough pain, and then slowly come down on the long acting formulations, and then hopefully switch to the immediate formulations.
Okay, great.
It's challenging.
Yeah, we do find it challenging in the office as well, no question about it.
Mm-hmm.
All right, well, thank you so much. I do want people to know that Megan is available. Some of her time is blocked this, so please, please feel free.
There's one question there.
Yeah, let's see. A couple of questions here. Can you please comment on how best to approach a new patient that's been previously prescribed opioids for years, and the doctor retired or something, now wanting you to continue a prescription you may feel to be not appropriate, or that be not what you would choose to do?
Yeah. Yep, this happens all the time. And I think, again, you want to use your resources, Dr. Baraveld in the Pain Center and myself, but it's important to have a very honest and transparent conversation with that patient. And really, in the end, you have to do what you believe is safe and appropriate for the patient. If they're on 90 MMEs a day, that, once you explain to the patient that that's really not a safe dose, it's associated with increased chance of overdose, and that probably the higher dose is really not giving them any pain relief. And then make a decision about how you're going to taper them down slowly. I think reassuring the patient that you're not just going to leave them without pills, that you're going to continue to treat their pain, and that treating their pain is really what you want to do, and then gain their trust, and then slowly decrease their long acting doses to a target of 50 a day.
Okay, 50 is the target that you like to use in your practice? I
mean, I prefer the lowest possible, but if they're on 90, I think getting down to 50 is the first goal.
There's another question here, and it's something that a lot of us struggle with, trying to get our patients who have Medicaid into a pain clinic or to a place that'll prescribe opioids. Of course, about the Boston Pain Center. Some of those places will, but they only take private insurance. Any thoughts on that?
Yeah. Well, my thoughts are that I use pain clinics really as consultative services, and not, I think that really, as primary care doctors, ideally, we would be comfortable prescribing these medications when they're recommended by the pain clinics. We really are the ones that have the infrastructure in place to monitor these prescriptions. And what I do is I send them to the pain clinic at Newton-Wellesley Hospital. I get the recommendations. And then if I feel that comfortable and I feel that it's medically appropriate, I'm the one who prescribes these medications.
Right.
That's how I use the pain clinics. Most of the pain clinics don't prescribe. I mean, I know there is one, but most of them are consultative services. And there's such a demand for those services that if the pain clinics take over also all the prescribing, they'll quickly maximize their capacity.
Yeah, but and just to follow up on that, sometimes, so we send someone to the pain clinic and they say, oh, they're on way too many opioids, you need to taper, and they send it back to us.
Yeah.
So then,
Well, then I think the question is to them is, help me taper.
Right.
And they'll do that. They will.
It's a patient that's not on board with that plan sometimes.
Right. And that's what has to happen.
Dr. Finn has a question about, should we expect inpatient docs to monitor the pain meds during the hospital stay?
Well, I would think so. In general, you mean I guess if the question would be if a patient is on chronic pain medications and they go into the hospital, then I would think if it's a complicated pain situation in terms of post-operative, that a hospitalist consult or a medical consult would then happen so that the two teams could manage the pain together.
Can you hear me?
Yeah, go ahead, Len.
Yes. Hi, Dr. Finn.
Okay, so here's the situation. The patient goes in for a non-pain problem, some ordinary medical problem, and they're in the hospital 4 or 5 days, and they're chronic medication patients who are high dose. And what would be helpful is if the nurses and doctors taking care of the patient really monitor how often the patient asks for medication, so that we see what their real baseline use of medication is instead of their report of their baseline use. But I haven't yet succeeded in getting an inpatient service to do that level of monitoring so that I have an accurate assessment of patients' medication use when they leave the hospital. And I wonder if I should be expecting it, and if you have any advice how to gain that consultative response for future admissions.
I guess what I would do in that situation is call the hospitalist who's taking care of the patient and talk to them about it. I do think the need it's probably not an equal situation in terms of a patient being in the hospital and a patient being at home. I don't know that their pain requirement will always be the same in those two situations. So may not be all that helpful, but I think direct communication with the doctor who's taking care of the patient would be what I would do.
And then there's, I see Dr. Whitcow is on the call as well. I also want to call out our pain psychologists over at our pain center. They can be very helpful. So not just referring, for pain management, but also for pain psychologists. Alan, I don't know if you wanted to take 2 minutes to talk about the services, if you can hear me or not, but I know I've sent my patients over there, and that's been a great referral as well. So
yeah, that is a really great referral, and it's a really fantastic service, and it's helpful to people.
Okay, well, we wanted to get Megan out in front of you guys because she's a resource that we can use on top of MixStap and other as we try to manage these patients successfully in our PCP offices. Please feel free to reach out to her, as I said, by email, by clinical message, and also I've also used a lab e-consult, can be quite helpful for any lab abnormalities, but particularly when it comes to these urine toxins. In fact, if you ask them, this is their biggest, line of business when it comes to lab e-consults is on new toxins. So don't be shy about that.
Yeah, when I spoke with them, they were very enthusiastic and they really want more consults.
That's correct. Thanks again. Hope everyone has a nice weekend and everybody rooting for the Red Sox this weekend, and we'll see you all next week. Bye.
Thank you. Bye.